Just want to go through our usual disclaimers real quick, and then we'll move into roll call as usual. So just want to let everybody know that this meeting is being recorded and live streamed on TVW. It will be shared on the State versus Blake ESB 5476 page as well. It is open to public disclosure, so please do not disclose any private or confidential information. For public feedback, there will be 10 minutes at the beginning of the meeting and 10 minutes near the end of the meeting reserved for public comment. Each person will have 3 minutes to provide feedback. If you are not a committee member and you would like to make a comment during a particular discussion, please raise your hand for facilitator awareness. If you're, and I don't mean on video raise your hand, but use the Teams hand raise feature. And then public comment on that topic will be invited before moving to the next agenda item. Feedback that is not provided during the meeting can be submitted via email at any time to hcaesb5476@hca.wa.gov. And with that, I'll go ahead and move right into roll call. Michael Langer.
Present, and good morning.
Good morning. Amber Leaders. Senator Dingra. Senator Braun. Representative Davis. Representative Griffey. Caleb Bantagreen. Don Julian Saucier.
Good morning.
Good morning. Chanel Wolf.
Good morning.
Good morning. Alexi Orr. Amber Daniel.
Morning.
Good morning. Brandy Flood. Stormy Howell.
Good morning.
Good morning. Chad Enright.
Hello, I'm here.
Good morning. John Hayden.
Good morning.
Good morning. Sarah Melfi Klein.
Good morning.
Good morning. Sherry Candelario. James Tillett. Christine Lynch.
Good morning.
Good morning. Sarah Gillard. Donnell Tanksley.
Good morning.
Good morning. Malika Lamont.
Present.
Good morning. Addie Adwell. Kevin Ballard.
Present, thank you.
Yeah, good morning. Hunter McKim. Representative Taylor. Representative Mossbrucker. All right. So any welcoming comments, Michael, before we move into the public comment period?
Sure. Thank you, Michelle. Thank you for kicking us off, and as always, for preparing for these monthly gatherings. Just really, again, appreciate everyone being on the call this morning. Last week was pretty eventful for us in terms of having sine die, I guess about 8 days ago now, having the legislative session come to a close, and a budget passed for behavioral health in general. We did see an increase to our budget for DBHR. However, there is a lot to analyze in the budget as it passed, both in response to what was in the 5536 that did not pass, and how that connects in with some of the opioid settlement funds, and just a whole lot of other proviso line items. I think we ended up being in the neighborhood of 115 or 120. Kim will give us an update in a little bit, but that's how we're spending our time right now, is trying to get through and answer the questions. We have a lot of inquiries from stakeholders, providers, the media, as to what came out in the end and what things we can pursue and which things we're going to have to retract from or not do that we were hoping to be able to do. So I know you were all very much watching session, participating in session, testifying or sending in comments. So thank you for being fully engaged. That makes the session much more rich. And just at the outset, we might expect, although we don't know yet, that a special session may be called between now and July 1st. And as soon as we know anything formally or officially about that, you may hear before we do if it hits the press, but we will be sure to communicate that with you all. And with that, I just, again, really appreciate you all being on the call today and look forward to a rich couple-hour discussion here. So thank you, Michelle. I'll turn it over to open comment, public comment.
Okay, good morning. We have 10 minutes for public comment. If you would raise your hand using the team tools there, we'll get you called on and you make your statement. Doesn't look like we need anybody right now. Again, okay, thank you. Megan Tweedy.
Hi, everyone hear me?
Yep.
Yeah, okay. Good morning. My name is Megan Tweedy, and I have been attending these meetings for almost a year. I've missed a few here and there, but I often say that I represent the human toll of the opioid crisis and the voice of the dead. In a world without stigma and shame and the proliferation of fentanyl, my brother Jeff might be here speaking instead. But I am the second best left to pick up the pieces and to activate change. So there are people out here like me who want to see their loss turned into something meaningful and are willing to do the work, to keep showing up despite the setbacks, the hurt, the fear. And one of those barriers to creating advocates like me is the amount of time it takes to acquire the depth of knowledge that you need so that you aren't speaking only from a platform of grief. So you aren't categorized and dismissed as emotional. So in addition to spending that time learning about these systems, you are also spending a lot of energy trying to prove yourself. So those of us who did not live the journey of walking side by side with our loved ones with SUD are even more at a disadvantage because during our grief, we're also learning these systems and witnessing a lot of polarization and a lot of painfully loud voices. So I've shared my recommendation before, and I just want to emphasize it again. We need more people to tell their stories. We've all heard that people don't remember what is said, they remember how you make them feel. And how we get those personal stories out there is by mentoring. And if we are not mentoring those in grief to foster advocacy and to tell their stories, then we're just going to keep kind of returning to this battlefield of polarization. So I would say as a newbie coming into this, that the first thing I learned, probably the most painful lesson, but with that acceptance, is this isn't actually a public health issue. It's not even a political issue. I think it's an issue of who has the power and who is speaking the loudest. So the grief community has to get louder, and it's a lot to ask. So here are my 2 points before I wrap up. I just want to encourage you all, if someone reaches out to this committee, to the communities you work in, and they keep showing up, that you also remember to invite them in and to facilitate relationships, perhaps with the goal of getting them to testify. So the recovery community has a strong group. They're admirable. The newly grieving, not so much. So the thing that keeps me going the most is really the work that the HIV/AIDS community did. And I show this graph over and over. And it's how they came together and activated and turned the graph into a downward facing momentum. So my last comment, what we can do is on Friday night, I drove to Ellensburg. I'm from Eastern Washington, to a treatment organization sponsored event, and there with the idea that there would be a local Eastern Washington state representative there who I could ask about his no vote.
No, I called
And
the Bellingham, Washington store.
so what I'm not going to get to any of that.
No,
What was
only way
shared
that
but
you
wasn't
can
shared, other than my experience of inviting a newly grieving mother whose son had died by fentanyl overdose. And during the time we spent there, and as she accompanied me to approach the representative and ask about it, there were 6 words that were never spoken. And as a reminder to you all, please speak them. And they are, I am sorry for your loss. Because her pain and grief was not seen or witnessed, and Nancy, will not be coming back. It's too much to ask. It is a lot to ask, and so I encourage you, keep fostering relationships for those in grief, and please remember to say the 6 most important words when everyone tells you about a loss. I am sorry for your loss. Thank you.
Thank you. Any other comments?
Yes, we do.
Look, I'm just going to say, Megan, we are sorry for your loss, and the woman that you took to the meeting also. Really important, powerful words. Thank you for sharing.
All right, Deontay.
Oh, yeah. My name is Edward Hoey Jr. I'm a member of Vocal. I'm a person who's recently been taken off the street, but I've been homeless for like 10 years and struggle with drug addiction. And I'm new to this, and I just wanted to just share real quick, like I appreciate anybody in healthcare and everything they do, and I know you guys that the MTs deal with a lot, nurses deal with a lot, but me myself, as someone who's identified as a drug user, I've been treated like dirt at some of these hospitals, and I've had my stuff taken, and it's kind of like hard for someone like me to be like, hey, this is happening, because they're like, oh, you're on drugs, he's crazy. And I don't know, but I'm not one to try to get someone fired from their job or nothing like that. Somebody needs to do something about it to where people who need proper care are being disregarded, thinking that, oh, they just want to get a free high or have a bed to rest up for a couple of hours. Like, they'll send you into this. I had an infected finger, and I left with more pain than what I came with. And they really didn't do anything but give me an aspirin and tell me pray and have a good day. And I got more care out of local clinic, like on a corner little mom and pop school type deal, than at this hospital.
Mhm.
And it just it bothers me.
Mhm.
And I didn't know who to talk to about it or where to go, what avenues to press.
Yeah.
If I should, I was kind of scared, like, what I get. Would anyone take me serious, or
Mhm.
you know?
Yeah.
So, and I just saw this moment as a chance to say something. I haven't said anything to anybody, so thank you for letting me say that.
Thank you very much for speaking. And just let me add, like, this is a space for you to speak on it.
Okay.
That's what the SURSAC is for. That's exactly why they have the open forum. And we need voices like yourself in this space. So we thank you for being here. And thank you for sharing your story.
Amen.
It's okay. Thank you.
Yeah, thank you. Thank you for speaking up. Appreciate it. Thank you. Any other comments? Don't see any other hands, so we'll go ahead. Michael, did you want to talk about?
Blake, there is a
yes.
hand up.
Deontay Deontay just spoke, or he had somebody else speak. Thank you. Okay. Any other hands? All right. Next topic of conversation here, Michael, Michelle.
Yeah, so now is where we would like to invite Jason McGill to share some information about Medicaid benefits that are changing for incarcerated individuals. We did originally have this later on in the agenda, so I apologize for the last minute change in that way, but just due to scheduling conflicts, we need to bump it up. So with that, I will hand it over to Jason. Thank you so much for this update.
Thanks, Michelle. And that's my fault. Our friends and colleagues at CMS have invited me to a meeting at 10 o'clock, so I have to attend that. And it might just be important for everybody to understand Medicaid here is a state-federal partnership. So the people at the Centers of Medicare and Medicaid Services, CMS, the federal agency, part of Health and Human Services, is who we work with for Medicaid. And the news I have today to share is that there's a historic first opportunity for payment of Medicaid services while people are incarcerated. And that is from a local jail point of view, a state prison point of view. And then there is in addition, a full service benefit for juveniles in rehabilitative detention centers or Juvenile Rehabilitative Administration, JRA, the state program. So that is all brand new. Official guidance released just a couple weeks ago. The state of California, along with a number of other states, including Washington, has been working with CMS over the past, year or two on this idea. It stems in part from the Support Act from Congress a few years ago now that instructed CMS to take a look at whether they can, what they call a waiver of law or rules in the CMS Medicaid world is available for states to ask for demonstration for pilot authority to pilot new programs. It is called 1115 code, and we call it shorthand 1115 waiver. And so for the first time, CMS is now going to consider state waivers for what is the inmate exclusion rule. And I'm sorry to get in the details, but it's, I think, important for everybody to understand a little bit about Medicaid does not pay for services in jail, including SUD, including pharmacy services, et cetera. So this is historic, this is important. So for the first time, CMS will pay for what is a limited set of services. It is case management, so to ensure people have treatment availability and actual referrals and appointments once released. People can have all services related to SUD pharmacy treatment, especially opioid medication treatment. and for upon release that there is a 30-day supply in hand, not just a script written, but in hand. So that requires immense coordination with the healthcare system upon upon release. And that's just the mandatory set of benefits. The secondary set of benefits, which we are going to also pursue, includes lab and radiology, includes behavioral health screening and targeted treatment, other chronic care conditions, Hep C, HIV/AIDS treatment, includes also pharmacy full scope treatment in carceral setting. So that alone, the pharmacy piece alone will be an extraordinary benefit, not only for the people served, which is of course our primary goal here, to ensure we have some treatment availability. And then I think CMS has been very clear about the goal of ensuring people receive treatment and referrals, not just referrals, but actually appointments scheduled with community treatment providers. So we have a strong system built there. But you might ask, well, how are we going to pay for this? Or how are, what is CMS requiring with regard to some of the financing? These waivers require strong evaluation from states to ensure that it is cost effective. So it really has to be sort of cost neutral. And so we're working with CMS now to develop an evaluation along those lines. Secondarily, more importantly, perhaps for our communities and the people we serve, you may be familiar with sort of a concept of you cannot supplant funds that are, let's say, local jails are already using for some healthcare services. And just because Medicaid now will start paying for those services does not mean local jails can just pocket that money or spend it on something unrelated. So there's a non-supplant requirement that really is a community or jail healthcare investment requirement. So that money must be spent and reinvested in the health system. Again, both in jail and outside of jail for those important related health, community health transitions. And that could include supportive housing and other sort of non-traditional healthcare supports that are important for our communities. We are still working on the details with regard to all of this. In fact, just this weekend, received some some draft language from CMS. So we're really progressing well here. But thought we would just give you a quick snapshot of this work, this incredibly important work, and also mention our sort of partner committee here, a statutory committee with regard to what we call reentry, our reentry advisory work group, a statutory committee that helps us in this regard. Is also sort of very engaged. We have a survey out to local jails now to understand readiness, because this will likely be one of the most challenging implementation activities that Medicaid certainly has been involved with in some time. So let me pause there, Michelle. I know your time is valuable this morning, and happy to take questions, or I could talk about this all day as it is so critical and important to our work. But let me pause for questions or any other thoughts.
There was one question in the chat about is there any website or reference for this information that we could share?
Yes, I can find some information and add that into the chat. Thank you.
Oh, another question from the chat from Representative Davis. Jason, thanks for the info. What's the timeline? When does this new billing authority go live?
Thank you. Thanks, Rep. Davis. So implementation, we're still working on some details with CMS now. We're looking to California for some model timeline. California, for example, will begin sort of what I'm calling a cohort of jails who are ready. Services January 1, 2025. So just based on California alone, I don't predict we will be able to do anything sooner than that, because the readiness review that CMS requires of jails will take some time to ensure that the inReach service, the case management service, the pharmacy for SUD is available, and the pharmacy upon release is available. But for those jails who are ready, I'm envisioning a sort of a cohort design that every sort of few months, 6 months maybe, we would do a review, and a cohort of jails who are ready can begin, let's say January 25. Might not be until July 25, depending on how this all shakes out with particularly local jail readiness. And then for the next 6 months, we'll have another cohort review and readiness. And that may include the secondary set of services, the lab and radiology, the full set of pharmacy, et cetera. So in a nutshell, that's how we envision right now how we would implement this. And again, working on some of the details now with CMS, making, I think, some good progress along those lines.
Any other questions for Jason? Oh, speaking of acronyms, CMS.
I tried to define that one first off. The Centers of Medicare and Medicaid Services, that's the federal partner we have to work with in Medicaid. Medicaid, as you may know, is a federal state partnership. So it's a joint program of which the feds pay half and the state pays half generally for the services for Medicaid, which is really our safety net program for people with very low incomes who do not have other health insurance opportunities through employment or otherwise. And so very critical program in this regard. So Centers of Medicare and Medicaid Services.
Thank you. How about the question about drug testing? See that. Thank you.
I see. Thank you. Let me take that back. I'm almost certain it would be covered under medical necessity, and drug testing is fairly standard for certain coverage. So let me take that back in terms of specificity. The nuance there is readiness and the definitions of the first phase of services, the mandatory services versus the non-mandatory services. Almost certain that would be allowed in the non-mandatory set of services. So the second phase of set of services, lab and radiology. There, I know it would be covered. The first phase of services are a little bit more basic, but important. That transition services, the care management, SUD, medication, and pharmacy upon release, I do not think it would be covered as part of that first set of services. But again, I think it would be as part of the second set. So sorry to get into the level of detail there, but you know, these definitions can be important when we are working on implementation here.
Okay, we have a question from Sharisa or comment. Dr.
Maybe
Potina?
I can add a few. Yeah, thank you. You know, I wonder to the question about whether or not drug testing would be covered. Seems to me that's a discussion we will want to have with CMS on the early phase. I think if someone comes in and they are on medication for opiate use disorder already, continuing that is fairly straightforward. If someone comes in that has not been on medication and requests it, certainly point of care urine testing to be able to tell if that person has opioids or some other substance in that setting, you know, would be very reasonable to determine whether or not which medication would be appropriate. So I do think if the expectation is to start people newly on medications for opiate use disorder, if they desire them, then we would need to have point of care testing, which is, yeah, requires some hoops, but is easier to do than collecting specimens and sending them to labs. So certainly something we should look into. So thank you for that comment.
Thank you. Okay, any last questions for Jason? Comments? All right, thank you, Jason. Appreciate your time and your
Thank
update.
you, everyone. Take care. And just
All right,
adding in
bye-bye.
the chat here some of the link to the official guidance from CMS about this. Thanks all.
Thank you. Okay, next up, confirming public safety discussion formats and guests. Michelle?
Yeah, thanks. Yeah, thanks, Blake. So we've been reviewing the Menti responses from the last meeting and trying to put together a framework for the discussion that we'll be having around public safety and substance use. And we just want to make sure that we're all on the same page around this before really finalizing how it's going to look. So just wanting to confirm the objective and then also next steps to ensure that we have who we need to have at the table for the conversation. So just want to confirm this as the objective for the meeting. If anyone has comments or slight edits or anything like that, please let me know. But the objective for this would be to expand awareness and co-education among attendees around the range of experiences that people are having with regard to public safety and substance use across the state. And sorry, and I'll pause there. Are there any responses or even just like thumbs up confirmation that that's what we want to be doing with this discussion? Okay, not seeing any responses, so I'll take that as this is okay. And so to that end, one of the things we looked most closely at was the recommendation suggestions of people that you wanted to have included in this conversation above and beyond the members of the committee. So we created this list and it's a lot of people. And so it seemed to make sense that HCA could take responsibility for sending out invitations, but we'll need SURSAC members to help us identify contacts in certain areas that we may not have the right networks or the relationships to do that ourselves. And so in the left-hand column are the folks that we feel pretty comfortable we can get those people there. In the right-hand column are some of the folks that will need your help with identifying contacts to invite to the meeting. So I'll give everyone a moment to take a look at this and just want to, again, make sure that we've captured all the different perspectives, voices, experiences that you want to include at the discussion. And if anyone's got, want to react again with thumbs up or a comment if something doesn't seem right here, please let me know.
Michelle, if members do have individuals they would like to have us invite in for the conversation, how do you want them to get that information to you? Just send you an email directly with the name and sector or who they represent and contact information? Is that straightforward enough?
Yeah, thanks, Michael. So I will send out this list in a follow-up email, and so that you can have it to reference. But if you do know someone that would be interested or that you'd like to have an invitation extended to for that discussion, that meeting, just send me an email. If you can, copy the person to give a little introduction to the both of us, and then I'm happy to send the meeting invite to them, or otherwise make sure that they know what the discussion is about and give them some context for that, and make sure that they're available at that time. Or if they're not available to attend the meeting, that we also can incorporate their comments in some other way.
Michelle, you see Malika's got a
Yeah,
question
just saw that. Yeah, when will this conversation take place? Planning on having it in June. And what is the format of this conversation? Yeah, so great question. I guess I'd like to open that up to the committee members. We could develop a few prompting questions, or we could have the conversation just be very open-ended. It'd be great to get some feedback. around how you want to format the discussion.
Question about, are we going to be adding tribes as well? Urban Indian organizations?
Yeah. Yeah, I mean that sounds like that makes a lot of sense. We should have that in there. So let me do that.
Michelle, also maybe just a reminder, these sectors or categories of respondents came from the Mente at the last meeting, right? These are the
They did.
folks that came forward. So you may look at this and realize, yeah, there's elements of our population or community that is not represented on here. So like bringing forward the tribes, if there's others, let us know. Malika, I think, touched on the challenge was how do we have this conversation with, 25 different sectors of folks here. So we are looking for your thoughts on that. As Michelle said, we can do 2 or 3 questions and just let the answers flow from the individuals invited in, or if you have another perspective on how you want to spend what would be probably an hour and a half of the 2 hours, I imagine, probably take quite a bit of time. Let us know what that is.
Mm-hmm.
Is June realistic? There's a question down there.
Yeah, if I can get the contacts in the next, this week, I can get them sent out, and with 3 weeks notice before the next. Actually, our June meeting is on the 12th, so we have an additional week more than usual to get this prepared. So I am optimistic that it's realistic to have this discussion in June.
Thank you. And Nicolette had a suggestion there as well, as far as Office of Behavioral Health Advocacy. Excuse me. That word. Sorry.
Great, thank you. I will write that down.
Thanks. Okay. Anything else, Michelle? Oh, I have a hand up. Sarah,
Yeah.
Go ahead.
Yeah, when we're speaking to public safety, is that safety for people who use drugs, safety for the larger, just general? I mean, public's a very general term. So I guess I want to return to the spirit of the question to know a little bit more about maybe who should be represented, who's not on at the table, or maybe some good folks to invite into the discussion.
Yeah, so the impression that we were getting based on the Menti responses is that the discussion should be as broad as possible with the voices that are present. So it includes all the people that you mentioned, all of the other people listed here, that we want as many of the perspectives to be present as possible to understand the range of experience around this issue. I hope that answers that.
Yeah, I think I might have missed the meeting where the initial request was brought up. I was there when we kind of brainstormed what public safety means, but I guess I am assuming someone originally brought up the request with something somewhat specific in mind. So just want to make sure that we're capturing that spirit in the discussion.
Yeah, and I can try to find the exact language, but it was something along the lines of how do we improve public safety without stigmatizing people and also helping them get the the help that they need. So I think the idea was that we have spent a lot of time discussing the needs of people that are using substances, and public safety applies to them, certainly. But then this was also to open up the discussion around other people's experiences around that. But again, it's everybody, we want to represent as many different people as we can in this experience. So we're not narrowing it down to a particular group. Yeah, sorry. Malika, you've got your hand up. Go ahead.
Question I asked about like feasibility of this.
that week is actually when a lot of people across the state are going to be graduating, like for youth. And so I think a lot of people on this panel and maybe other people that we want to invite into this, it might not be a good time for to get a good turnout. That's my feedback on something to think about
Okay.
for the time frame.
Okay. Yeah, that's definitely something to consider.
Because if we're going to put all this effort into putting together a substantive conversation, it would seem like we would want to make the conditions ideal for as many people to show up as possible. And since that is a big, like that week and the following week are big times of graduation for both like high school and colleges. So just think in Washington. So just to think about that.
We also have Michelle that you've seen the chat, another addition to the list, reentry council members.
Oh,
All right.
thank you, Keisha.
Hey, Michelle, anything else on this subject?
No, I hope to get a bit more feedback over email when I send this out. And if anyone else has concerns about the date and the graduation potential conflict, please let me know. I'm certainly not against, pushing this to a later meeting. So I guess we'll figure out what to do about that. But if anyone has comments or other contacts for this list of people, please, please let me know as soon as possible in case we do end up having it in June, on June 12th, because I'll need to get those invitations out as soon as possible. I think that's it.
Michelle, I would also say, I looked it up, it's a Monday.
Mhm.
And to Marika's point, it is a busy time with graduations. July and August are also busy times with vacations. And so trying to find the perfect time may be a little elusive. In terms of format, we didn't really get any feedback on some leading questions versus another option. So if we don't hear, I assume that we'll go with the leading questions and try to elicit as much feedback from the different sectors being invited as possible. So thank you.
All right. Malika, go ahead.
Well, and just thinking about the format, like one of the things that I'm concerned about is that it is going to be a situation like there's not going to be like how are we going to create a situation where people get to have at the very least equal ability to be able to speak from their perspective and that their expertise is recognized. Of course, I would hope for equitable, but at least if we could get equal, because this is a huge group of folks. And can we talk about like what the format would be, like have a meaningful discussion and maybe invite other folks into that process about how we're going to create a meaningful engagement? Like, what does that look like exactly?
Malika, are you suggesting a separate meeting to discuss how to set up this discussion with some specific other people?
Yeah, I mean, actually, I'm wondering what other groups, what other members of the SURSAC and individuals that are on the call today think an equitable, like I said, I'm shooting for equitable, but at the very least equal conversation would look like to be able to do this justice. Like, does that mean that we have panels of people that are within each one of, or, like within these sector, like that are connected by their sector or whatever from this list, that they're speaking to the whole group. And then we have, question opportunities, but that everybody's given the same amount of time to speak, and that they're able to, share their perspective from, their vantage point. And then we have a robust conversation amongst ourselves about it. But between everybody, and that we can ask questions, including, folks that are attending the meeting. I think, that could be one way to look at it. Or what do other folks think about ways to make sure that we have an even and equal exchange in this process? I think there's other hands up. I see hands up.
Yeah. Yeah, Lakeisha?
I think that one of the things may be first actually going back to what someone else said earlier. Changing it from public might be a good idea, and changing it to community, because community is already inclusive and public is not, just historically. So I'd probably change the language about what our meeting is, because that actually tells you in the name who's invited. And I think community is way more inclusive. But also, I think the use of polling would be important during this meeting, so that if there is a vote or an idea put forward, someone's voice, if they took up more room, which sometimes happens often, was not heard above what the collective and what individuals were.
So, Lakeisha, just to clarify, in order to prepare polling, we would need to have like predetermined questions and then ask the group those questions. Is that how you're imagining that working?
Well, do you have to have predetermined questions? Because you're using Teams right now. I think you could just make one if you have the Teams app. I'm not on my laptop, so sorry, I can't just pop
I
one
was
up real
thinking
quick.
about,
But
no, you're right. I was thinking about using Menti, and those have to be predetermined. But if we're just using the hand raise feature for things, but that's really more of like if the polling is a yes, no situation, or support, don't support, right?
on the polling in Teams that Microsoft uses,
HCA doesn't have that. There's certain accounts
oh, okay.
that, yeah.
That's okay, cool. Okay.
Yeah.
Then I don't know. I'll think about it though.
Okay. That's a great suggestion. So we'll think about how to incorporate that. And then Malika, you had suggested using like a panel format. I'm curious what others think about using that, like having designated time set aside for specific speakers, maybe, I don't know, 3 minutes each or something, just to make sure that we hear from that wide range of folks, so that they don't need to worry about inserting themselves into the conversation. But this is the time that we really, really need to hear your feedback so that we know how to move forward with this. And so if you have thoughts about how you want this conversation to look, please speak up.
All right, Michelle, we have a couple more suggestions here in the
chat.
in
Okay.
the chat as well. So if you want to check those out.
Okay, great.
And to be more clear, what I was suggesting was that each panel, like we do it by sector. So for example, if there's going to be a public health sector, that there's a panel of people that are, represented in that group, local elected officials, housing first providers, and then maybe crisis response. So that would be like 988 staff, RMP staff, mobile response teams. Do you see what I'm saying? Like that.
Yeah.
So that all those individuals are on that panel potentially. And then Yeah.
Yeah, I like that idea. All right, I think we're past time for this agenda item now, so I will move on, but I think we've got some great ideas for how to format this. And so again, in a follow-up email, I'll confirm where we're headed with it. And I appreciate all the ideas. So thank you so much for those that contributed. All right, so Kim, are you on and ready for the legislative session overview? All right.
Hang on with me while I try to share my screen and get my tech working. Thanks for having me this morning. All right, good morning. Kimberly Wright, Behavioral Health Operations and Planning Supervisor for Division of Behavioral Health and Recovery. I was asked to come this morning and just kind of give a brief high-level post-session update. We are just about 8 days, if I can count, out of session. So very early stages of review on both the budget and the newly passed behavioral health policy. And of course, as you know, we dig into this and get the details, and we'll come back with more updates and those details to share on what I'll cover today and maybe different programs or other information that you're interested in. So very high level. I'm happy to take questions and take those back to teams that will be working on this. And with that, for the 2023 to 2025, the biennium community behavioral health budget, we see total appropriations of, I think that number means 5 billion, just over 5 billion. And then we have an increase this year, as kind of Michael mentioned earlier, that increase is just over 350 million this biennium, not this year. That with that is 124 provisos. Those are new and continued behavioral health investments. We at HCA are still reviewing and determining changes to continued programs and strategies for the new implementation, and just how those new provisos and the impacts that they'll have. And I have some behavioral health policy passed legislation to cover this morning for you. We have House Bill 1515, which is contracting and procurement requirements for behavioral health services and medical assistance programs. This has HCA making changes to the managed care procurement process, including adopting regional standards for behavioral health networks managed by managed care organizations, providing behavioral health provider participation in the process, and evaluating options to reduce provider administrative burden. And as you have questions, please feel free to put them in the chat or follow standard meeting procedures. I can't see the chat, but assume that Michelle will help me with that if there's questions or I need to slow down. For Senate Bill 5440, concerning competency evaluations, this is requiring a court to determine by direct observation of a defendant that there is genuine doubt as to competency before ordering the evaluation, and a number of other assurances that go with competency evaluation. Senate Bill 5634 with problem gambling established the Advisory Committee on Problem Gambling to be an ongoing entity that meets on a quarterly basis. It increased the rates of transfers and taxes into the problem gambling account, which doubled the amount of funding to the state problem gambling account by a state fiscal year 2025 through that increase in the percentage of business and occupation tax from commercial gambling, lottery, horse racing, and charitable gambling. And then it clarified that the existing but inactive Problem Gambling Advisory Council will be hosted by HCA and will be responsible to track the Problem Gambling Task Force recommendations and emerging issues. And it also replaced the outdated term problem and pathological gambling with problem gambling and gambling disorder. For Senate Bill 5502, ensuring necessary access to substance use disorder treatment for individuals entering graduated reentry program at the Department of Corrections. This has requiring the assessment of incarcerated individuals with a substance use disorder prior to participation in the Department of Corrections graduated reentry program. It also requires substance use disorder treatment for individuals identified with that disorder during assessment, and requires monthly reports and identifying the number of individuals in those treatments. For House Bill 1168, the prenatal substance exposure and providing preventative services, diagnosis, treatment, and supports. This is in partnership with Department of Children, Youth, and Families and adds DCYF, Department of Children, Youth, and Families, to the Fetal Alcohol Exposure Interagency Agreement, and expands the agreement to include exposure to prenatal substances other than alcohol. HCA and DCYF will work in partnership to develop treatment and family support services for children prenatally exposed to substances. And then HCA will submit recommendations to the legislature on increasing access to diagnosis, treatment, and supports. For House Bill 1580, creating a system to support children in crisis. This has the governor's office maintaining a children and youth multi-system care coordinator, whose duties include creating and directing a rapid care team to support and identify appropriate services and living arrangements for children who are in crisis. And this office will be the state lead on addressing complex cases of children in crisis. This directs the membership of the rapid care team and identifies individuals who can make referrals to the rapid care team. And HCA will work very closely and in partnership with the care coordinator and the rapid care team for those complex cases of children in crisis. And then I feel like I'm going fast, so I'm just going to take a breath and see if there's anything out there for me, but we'll continue with Senate Bill 5120.
There is one question that just came into the chat, Kim. Yeah, from Malika. Why was alcohol excluded on 1168? Alcohol is one of the most harmful drugs for prenatal exposure. Do you know the answer to that one?
So it is that those, I think my answer, and I can take it back if it's not complete, is that alcohol was already considered and looked at, and this increases it beyond alcohol. So this interagency fetal alcohol exposure agreement is being expanded to include substances beyond alcohol. While alcohol is still concerning, still being looked at, and still being worked on, we know that there's a lot else out there.
Thank you.
I think that I'm on the 23-hour bill, dubbed the 23-hour bill, Senate Bill 5120, which is establishing 23-hour crisis relief centers. This has the Department of Health licensing and certifying 23-hour crisis relief centers, which is a new type of crisis diversion facility to serve persons regardless of behavioral health acuity. This expands services for behavioral health crisis care. 23-hour crisis relief centers are a facility-based care that does not require medical clearance, accepts all first responders and 988 referrals, and provides mental health and SUD services regardless of acuity, and offers minor medical interventions. House Bill 1134 establishes an endorsement for 988 rapid response crisis teams that meet staffing, vehicle, and response time standards, as well as a grant program to support them. This is continuing the focus on enhancing our crisis system and its response. We know that this is very beneficial to anyone experiencing a behavioral health crisis within Washington State and the country, right? That 988 initiative. Having the ability to provide a rapid in-person behavioral health response to those in need is likely to greatly improve outcomes and community trust in our behavioral health system. The development of comprehensive training curriculum that can be offered to a variety of responders will lead to a more effective response system. And then just adding that the increase in liability protections outlined in this bill will benefit those providing those calls. With 5189, the behavioral health support specialists, This establishes the profession of behavioral health care support specialist, has the healthcare authority ensuring that behavioral health support specialist services are covered by the Medicaid state plan by January 1st, 2025, and requires carriers to provide access to behavioral health support specialists who would work more in that primary care setting with lower acuity behavioral health needs in accordance with network adequacy standards established by the Office of Insurance Commissioner by July 1st of 2025. And then I think last but certainly not least is Senate Bill 5555 with creating the profession of certified peer specialists. This establishes the new profession of certified peer specialists and certified peer specialist trainee to be certified by the Department of Health, specifies training and educational pathways and requirements to earn a certificate to engage in the practice of peer support services, has the healthcare authority developing the trainings and examinations required to become that profession of certified peer specialist, and then establishes training requirements for certified peer specialists practicing as peer crisis responders.
Thank
And
you so
then-
much, Kim. Oh, sorry, there was a question in the chat?
And
Or a
a fast
comment.
note that
Can
I
you
wanted to
clarify whether these are considered passed because they're on the governor's desk ready to sign, or how far through the process have these gotten?
Oh, thank you. Excellent question. So as of writing the slides, these were all in the process of signing. So they've all passed from committee and are in the process of signing or various stages of signing. I believe at this time, some have been signed and some are in process.
Okay. Thank you. Representative Davis, go ahead.
Thank you for the excellent overview. My question is for HGA related to 5120. So this bill is not dissimilar in some ways to a SHMIC bill we had, I think in 2019. I think it was 1394 that established a few different types of new behavioral health facilities. But my question is regarding rate setting. So as you are all aware, this bill is Washington State's attempt to replicate the Arizona model regarding crisis receiving facilities as a meaningful alternative to incarceration and emergency department visits. However, in order to actually achieve the aims described in the bill, accept every referral or drop off, don't turn anyone away, don't require medical clearance, the level of staffing required to do that is high, particularly from a safety perspective. And so the rates that they are fetching for these facilities, at least in Arizona, are close to $1,000 a day and much more on par with the rates that we have, for evaluation and treatment services and such, and not remotely close to the rates that we currently pay for crisis stabilization units in the state, which many have gone belly up because of the rate issues. So the bill does not direct any actuarial rate setting for this new facility type, but my sincere hope is the magical elves at the actuaries will do that anyway, or you guys will direct them to do that. But is that going to happen? And if yes, what would be the timetable for that? Because my concern is these facilities will fail before they even open if we don't pay them a rate that allows them to do what we've directed them to do.
I see that Dr. Fortinos has her hand up, and so I would defer to her, or it looks like Michael might have had something to say.
Do you want to go first, Michael?
I don't have the answer, but we can certainly get back to Rep. Davis on what we anticipate the rates being, but I don't have that with me here today. Unless Teresa, if you have it and we're going to close it, go for it. But
no, I don't know. I just had two additional questions. One was there funding appropriated for this? And secondly, do you know, Rep. Davis, what the expectation for, I would assume the expectation was that Medicaid funding be leveraged as much as possible for these facilities?
Yes. Yeah, there was some money. Well, actually, I don't know, because there was some earmarked we did direct appropriations in the Blake bill that failed. It wasn't huge. It was a few $1,000,000, and that obviously did not pass because the bill didn't pass. I'm trying to recall if there were direct appropriations in the underlying budget, but there was no, my specific question is really more about rate setting. And is that something, is that a naturally occurring process when a new behavioral health facility type is designated? That's just going to happen without the legislature specifically directing the agencies to do that. And then regarding Medicaid, certainly yes, interested in maximizing Medicaid rates. We anticipate, of course, that in addition to the Medicaid population, these facilities will serve a lot of folks with commercial coverage who, our commercial carriers were incredibly gifted at skirting their crisis payment responsibilities for years. And my hope is that with the passage of House Bill 1688 from 2022, that will we will be able to hold their feet to the fire and require them to also pay for their insured individuals who are receiving services in these facilities. But I'm sure it'll be an evolving process. But again, I just by my unofficial estimate, perhaps the number one type of behavioral health facility that's gone belly up in the last 5 years has been crisis stabilization because of rates. So I just want to make sure, and King County just passed their levy to build a bunch of these, which is awesome, but only awesome if we have a rate that supports what we think they're supposed to be doing.
The rate process is pretty set as to how it's calculated and figured. Perhaps we can chat offline. We can find more information for you. It's pretty scripted, but there may be, happy to look and see if there are opportunities.
Awesome. Thank you so much.
Okay, Kim, I think you're clear to continue.
I think that's really what I have for the group today. And then just happy to take anything back or come back again as some of these details flesh out. And that my list of bills is certainly not inclusive of all behavioral health policy, just kind of the pinpoints of where we are right now. And thank you so much for having me.
Thank you. All right. So moving on to the next agenda item. So originally, well, a few weeks ago, we had set this time aside to go over 5536, which was the bill that included several of the SURSAC recommendations. As you may be aware, that bill did not pass. However, I did want to highlight something from the budget that is good news. So the Safe Supply Work Group was funded. It's receiving $300,000 to execute the Safe Supply Work Group. So wanted to let everyone know about that. And since Representative Davis is here, I would just, if you wanted to say anything about the legislative session in 5536, you're welcome to do so. You certainly don't have to.
Sure, I'm happy to chime in. I'm not sure if any of my colleagues have joined, but I mean, quick summary. So that bill passed the Senate originally earlier in session with at a super high level. When the bill passed the Senate and came over to the House, it had it was a gross misdemeanor. It had mandatory minimums for what they called failure to comply with recommended treatment, and the treatment infrastructure in the bill was the very traditional substance use disorder treatment architecture, right? So you get your ASAM assessment, you get placed into a level of care, essentially if there was a return to use or not adhering to treatment, you'd get yanked into jail. And then we had the House changed the bill pretty dramatically. We made it and that bill, I should say, when it passed the Senate, it passed 26-23 with the mandatory minimums, the gross misdemeanor, and the traditional SUD system of care, which again is an acute care model, which is not particularly effective or appropriate for a chronic disease like SUD. And that bill passed 26-23, but a very unusual set of bedfellows voted for it and against it. Like, you could not really trace the lines about what those people have in common. It was bipartisan, but weirdly bipartisan. Most of the progressive Democrats voted against it. Some voted for. it gets to the House transformed it quite a bit. We immediately dropped it from a gross misdemeanor to a misdemeanor. We also transformed the air quote treatment to make it more appropriate from kind of a chronic disease management model that recognizes the complexity of substance use disorder and the fact that it's really not just about SUD, it's about mental health, it's about social determinants of health, and directed the intervention to be either the lead model, the recovery navigator model, or the alternatives to jail and arrest, which essentially clustered together are all various versions of lead, which of course is evidence-based and highly effective for this population of individuals who are exposed to the criminal legal system because of their untreated behavioral health challenges. So we changed that, and then we deleted all the mandatory minimums. So that bill passed the House 54 to whatever 98 minus 54 is. So we had the only people who voted, the only Democrats in the House who voted against that bill it would have been 4 kind of ultra progressive Democrats who were just in principle opposed to the criminalization of persons with substance use disorder, which I also am, but I did vote for the bill as sort of a compromise. And then the Senate was unwilling to concur. So, obviously the same piece of paper has to pass both chambers for it to go to the governor. Senate refused to concur. It's my understanding the Senate said they didn't have the votes for for a misdemeanor. So essentially asking the House to cede to the Senate position. And in retrospect, the correct answer probably should have been, well, the House doesn't have the votes for a gross misdemeanor, which ended up being true. But they went to a conference committee. There was a proposal passed. I will say that the bulk of the SURSAC recommendations were in, most every version of the bill, so that was encouraging. And then the bill ended up on sine die on Sunday. The bill ended up failing on the House floor, which almost never happens. The majority party doesn't generally take a bill to the floor if we haven't vote counted and are certain we have the votes. But it was in fact, and we were also unsure that night if the Senate had the votes. And in terms of how it failed, all the Republicans voted no. They were interested in more sort of coercive tactics. And really wanted to have more penalties for failure to comply than the compromise proposal included. They were also, although I wouldn't say this was a primary, they were unhappy with some of the pieces related to, for example, removing public hearing requirements related to setting opioid treatment programs, some of those issues. And then I would say the primary reason that all the Republicans locked up and voted no is because WAPA, which is the Washington Association of Prosecuting Attorneys, and WASPIC, the sheriffs and police chiefs, both wrote letters in the 24 hours preceding the vote saying that they were opposed. And those two stakeholders are particularly in the ear of my Republican colleagues. And so they all voted no. So that meant you had to get 50 Democratic votes. Well, mind you, got 54 on a misdemeanor with a more therapeutic approach, but with a gross misdemeanor. And there were a few other changes that had been agreed to in the conference proposal, like retaining a public hearing for citing certain harm reduction facilities. And we just lost too many votes on the progressive side of the ledger who weren't willing to penalize individuals with SUD with a gross misdemeanor. So it kind of fell through the middle, if you will. All of the right voted no and the far left voted no, and it just didn't add up to 50. So I think it's very likely, extremely likely that we'll be called back into special session. There's conversations afoot now, trying to come up with a compromise proposal. I'll just speak for myself. I have non-insignificant concerns, just this is my worldview, that the quote compromise proposal is actually going to be more punitive for the population than the proposal that failed on the House floor, which I was not comfortable even with that proposal, and I'm concerned that what will be put forward will be worse. So It's a kind of a scary time, actually, for drug policy in the state. And I wish I had better news. But that's what I know right now.
Thank you so much for that summary and those updates. Now we have some time set aside for any Q&A related to what you've heard from Kim or about what to expect in coming months, the bills that have passed. So just want to open the floor to any questions you may have about the legislative session. And if there are none, we'll, oh, okay, go ahead, Sam.
Sam.
Mhm.
Hi, Rep Davis. I just am wondering if you could just, well, I mean, feel free to answer some or none of this, but if just getting your opinion on the state of the Senate and the House, it just seems like there's sort of a negotiating, well, potential negotiating impasse, and maybe even a game of chicken about which version would get through, because it seems like there wasn't enough votes in the House to get to a gross misdemeanor. I mean, what do you think is going to change there? And maybe it just comes to negotiations within the party, within the House, and Speaker Jenkins's position with other House Democrats. But just wanted to, I'm really interested in what you said towards the end there, and I'm wondering why, and why the Senate would end up getting its way rather than the House.
Yeah, that's a great question. I mean, if they're going to continue with I don't think you're going to get a Democratic vote out of the House with a gross misdemeanor penalty. I think we saw that on April 23rd. So I think that the way that you get to 50 is you make it more draconian and more of a quote hammer or quote stick or whatever words people are throwing around, and then you pick up Republican votes. You're going to lose more D votes than you already did if you do that. But that would be my hypothesis. To speak in super broad strokes, as a general rule, the Senate is a bit more of a conservative body than the House-ish, relatively speaking, on most issues. There are significant Democratic majorities, of course, in both chambers. I'll just say as both a legislator but somebody who works in this field, what's frustrating to me, and unfortunately, this is not going to be fixed between now and July 1st, but what is driving, if you were to read the prosecutor's letter opposing the compromise or the sheriff's and police chief's letter opposing the compromise, they are, and if you were to listen to the rhetoric in the floor debate, any of the floor debates on this bill, the resounding theme, the siren, call is, you've got to force people. You've got to kick them in the shins. You've got to break them down. You've got to let them hit rock bottom. You've got to have a hammer, and that is how you are going to slay this dragon and get them better. And the one common thing that everybody has in common is there's a genuine desire for people to get better. That is true for my Republican colleagues, my Democratic colleagues, prosecutors, police. Everybody wants these people to get better. But what's frustrating is that it's a deeply held belief by most of the general public and most of these stakeholder organizations that the way to compel behavior change for this particular disease is through increased quote sticks or increased criminalization or increased pain or increased negative consequences. And given that, of course, continued use despite negative consequences is one of the criteria to be diagnosed with SUD, such a posturing is really quite silly and defies everything that we know about the way that this disease moves and operates. I don't know how you fix that quickly, but that is what is driving all of this. And I just wish there was more of a better understanding of this disease and what motivates people in active addiction, what motivates behavior change, because there is such a deep interest genuinely among all parties in that behavior change, and it's just about the how. And until such a time as there is more of a culture of seeing and really understanding the felt experience of and the pain and despair that is active addiction, and the fact that it's actually hope that motivates behavior change. Until such a time, I'm just concerned that we're going to get some sort of giant, comically huge hammer and expect that to work.
Thank you. John Hayden.
Thanks, Rep. Davis. That was extremely well said. I'm wondering if you think that any bill that passes in a special session would include some form of preemption to get the cities out of the business of legislating this issue.
Yeah, that's a great question. And I'll just back up just for 1 second, because I know we have folks on here with varying levels of sort of legislative experience. So what the question refers to is if the state is occupying a particular area in law, then that preempts or disallows local governments such as counties and cities from making their own policy. So an example would be the firearm policy. The state preempts local governments they can't have their own gun regulations. Similarly, prior to the Blake decision, the state preempted local governments because the state was occupying the field, so to speak, regarding drug possession. In the last probably 6 months or maybe 6 to 12 months, what we saw, even though the state under current law occupies the space of drug possession by making it a misdemeanor with these 2 required pre-arrest diversions, that's current law until July, the state was not occupying the field of public drug use. And so we have seen a number of local governments being quite creative with different ordinances that one can invent, such as drug loitering, fentanyl use in public, et cetera, finding other ways to criminalize this population for essentially the same behavior, but calling it something different. And so what the legislature did in response, that was another addition in the House that I should have mentioned. So the House bill did 3 things. It criminalized possession as a misdemeanor. It created a new crime of public use. And while you might think that House Democrats would be disinterested in finding new ways to criminalize this population, in full transparency, we did that for the purpose of preempting local governments from doing what they have been doing, which is creating new crimes for effectively the same behavior. And we were also disinterested in creating an opportunity in which we could have local governments getting a double whammy. Like, we're going to get you on possession and public drug use. And so what we did is we made possession an element of the crime of public use so that you couldn't charge someone for both of those things. And so we were preempting the field of possession and public use. And then the bill actually said in the text of the bill that we were fully decriminalizing paraphernalia and preempting local governments from enacting their own regulations related to paraphernalia. So, and then the compromise proposal was similar. It had the public use crime, it had the possession crime, both of which were a gross misdemeanor, and then it had the paraphernalia preemption. A lot of local governments were unhappy with the preemption language across the board, and there was some pushback from the cities and then, of course, law enforcement related to that. So I'm not sure what's going to happen going forward related to preemption. I do think there's a general recognition that having a patchwork quilt of drug policy, where if you're on one side of the street, in unincorporated county versus within the confines of a municipality, that'd be complicated and messy.
Thank you. Malika?
I caught one of the things that you said, Lauren, about like a comically huge hammer. I don't think that, and I know you didn't mean it as it's funny, but like this is a race to the most punitive is what it feels like we're witnessing, and it is steeped in stigma and a desire for revenge. And we're taking revenge upon traumatized and vulnerable people for a crisis that was created by our prohibition-based policies. Like, fentanyl is directly related to the fact that we have an unregulated illegal market. And it is beyond the pale to me that we can continue to have prosecutors, some in this very group, in this very virtual room, that want to have more teeth to chew people up as if they're something to be destroyed, rather than to actually follow the evidence base to help them. And in the name of law enforcement and laws, that we ignore evidence about what actually helps people so that we can punish them in the name of quote unquote helping them, when we're making it harder to cite treatment facilities. That's what that requirement of a public hearing that could stop the process of citing essential services. Like, I think we need to really be honest with ourselves as human beings. It is not okay that people are suffering, no matter what side of the aisle that you sit on, as far as Republican or Democrat. And that we need to do what's right by people. We don't need to pummel them and hurt them and harm them. Like, that stuff never worked, and it makes it worse. It's just so sad to me that this is where we're at.
Yeah, thank you. Sorry.
I'm sorry, Lauren. But like this particular group, like we were convened in order to come up with a solution or come up with ideas. And some of folks in this group directly, undermined the fact that we were inclusive of other voices than have been traditionally included in these processes. So therefore invalidating the process. It's just sad to me. It's real sad.
Yeah, thank you, Malika, so much for those comments. And you're certainly preaching to the choir with me. Yeah, agree with so much of what you said. I mean, the first thing I'll say, sorry for not clarifying what I meant by a comically large hammer. I meant comically in the sense of, it's laughable that we would think that would work, that the larger the hammer would work, given obviously the failed policies of the war on drugs. It's so absurd, in my opinion, to build a bigger hammer in order to effectuate change, that it's almost laughable. But I probably should have chosen a different word. But to your point, I mean, I tend to be an eternal optimist, and I guess, what I do want to say regarding, law enforcement and prosecutors, and this is not just true of the organizations WAPA and WASPIC, but actual law enforcement, actual prosecutors are deeply and sincerely interested in people getting better, and I mean that, and I've witnessed that over and over again. There is just, incorrect beliefs that are sort of not based on evidence about how to do that. And again, I haven't quite figured out yet how do you change that opinion in short order. In my experience, the most effective way to change individuals' opinions is, of course, the testimonies of individuals with lived experience explaining what actually works to motivate behavior change. I often what will be cited then is the minority of individuals who say, getting arrested saved my life or jail saved my life, and that's totally true for them. And I don't want to in any way invalidate that experience. That's their own story, but that is very much the minority narrative, and we generally don't legislate to the exception because it makes poor public policy, and it's not based on science. But but I think that's where we're at a crossroads, and what you guys are experiencing, what we're all collectively experiencing, is a situation where the harms are really bad, right? It is, the fentanyl crisis is horrible. What's happening to families is horrible. The suffering on our streets is horrible. And so the public outcry for something to be done is so overwhelming, that the legislature is sort of grasping at straws and feels an incredible amount of pressure to act. And my concern is that we're just going to act in a way that counts to 50, 25, and 1, 50 votes in the House, 25 in the Senate, and a willing governor. And it's not going to be based on science. It's not going to be based on past history. It's not going to be based on effectiveness. It's going to be based on vote counting. And yeah, I wish I had better news.
Malika, did you have any other comments, questions? Thank you.
No, sorry, I just forgot to put my hand down.
No, you're all good. Thank you. Thank you for speaking up. All right, I don't see any other committee members on. So Megan, you have comments?
Yes, thank you, Representative Davis, for that summary. That was fantastic. Malika, thank you for stating what I have found to be obvious as well. No, we do not want to follow evidence-based solutions. And so my questions are directly from my presentation, the presentation I attended Friday night, which involved a state representative, Republican state senator, and I'm hoping for some clarification from a few comments he made. I will say what he shared with me personally was I wanted to vote, but there was nothing there. It had no teeth. And of course, this was in regards to criminalization. So my first question is, do we have any Republican representation on this committee? My second question, could you clarify for me, anyone, a couple comments that were made that night by the Republican senator, and that is health engagement hubs have kids and adults at the same facility, mixing users and non-users, and that was their rationale for why he could not support. I was hoping you could clarify that for me so that I can then clarify that when it comes up in discussion. And then my third question, oh, shoot. Oh, this particular gentleman was quite upset that when it went to conference, my party was excluded from the table. So I was hoping you could clarify those three things, if you got them all. Anyone?
Yeah, I can, if HCA wants me to jump in. I'm looking at your faces. Yes, okay. Yes, I have several wonderful Republican colleagues who are on this committee. The appointed House Republican is Representative Dan Griffey from Mason County. His alternate is the wonderful Gina Mossbrucker, who represents the Columbia River Gorge and part of Yakima, the 14th district. They are fabulous and care deeply about this population. And again, just different maybe way to different approach to solve, but they are extremely invested in people getting better, and I would go to the mat with anyone who tried to tell me that they're not actually interested in people's wellness. Just a different opinion. Senator John Braun is the Senate Republican, and I'm not sure if he has an alternate that was designated for this committee. And they've been attending. Senator Braun and Rep Griffey have been attending throughout the last interim and such. The comment regarding health engagement hubs, I think the comment that I heard in a floor speech from one of my Republican colleagues about mixing mixed milieu, so mixing individuals who are in active addiction and individuals who are in recovery, I think was actually in regards to recovery housing. And I think that was actually in reference to one of the SURSAC recs, which was in the bill, which had to do with creating sort of respite beds for folks who may have had a return to use or a relapse and need a place to sort of stabilize before returning to recovery housing. And I don't think the bill specified the manner in which that would occur. I would certainly agree that you generally don't want a mixed milieu, right? You don't want to have individuals in active addiction in the same living environment as individuals in recovery. That's pretty obvious, and data would suggest that that's true. I don't think that was anyone's intention, to be super clear. I think it was one of those things where like someone was preparing a floor speech and like lifted it out of the bill, like, oh, this looks like it could be controversial, and wasn't a party to all the dialogue that actually led up to that recommendation. I don't think that was actually in reference to health engagement hubs, although I'll just be transparent. I'm not sure health engagement hubs are entirely without controversy because, they're essentially a harm reduction model where they very effective. You provide, sort of a Fred Meyer of health services for individuals in active addiction, including harm reduction supplies, including wound care, including engagement to wraparound services, things like housing, but also treatment. Um, so I'm sure that for individuals for whom harm reduction is a hot button, I could see them latching onto that. And then the last point regarding lack of engagement of the Republicans, I'm an honest broker, and I'll just say that that's fairly accurate. And not to sort of justify, but rather to explain. I think this is so most behavioral health policy is not controversial. It's super bipartisan. This particular policy, unfortunately, can be quite partisan, and uh, the uh, the position, the desire was to try to have air quote a democratic bill, meaning unlike the version that passed the Senate, that was 26-23 with like half D's voting yes, half D's voting no. So the majority of the Democrats in the Senate, I think, actually voted no on the bill that passed. The House had a position. We were going to try to, um, you know, kind of cat herd within our own caucus to try to get enough Democratic votes to pass a Democratic bill. And that was really difficult in and of itself because we have a very diverse 58 members, right? We have more moderate Democrats from rural areas. We have swing district Democrats. We have very progressive Democrats from Seattle and everything in between. And it was difficult to try to thread the needle to add up to 50 Democratic votes. And then if you were to layer on that, uh, to bring some of the Republicans along, you you may have had to accept certain compromises, which then start to lose your Democrats on the left. And again, I'm just speaking transparently about how it all works. But that is not inaccurate categorization or characterization rather of the conversation. I generally try to operate personally in an extremely bipartisan way. In fact, the Blake bill, the 2021 bill, passed the House 80-18, and I was really proud of that. And that was a reflection of a lot of work that I personally did and my colleagues with the Republicans. I generally think we make better policy when we work across the aisle, and this was a pretty unique animal. But whoever said that to you was not wrong.
You're on, Megan, you're on mute.
Sorry, last follow-up. So there's no Republican representation here today.
I think Michelle can jump in, but I'm not sure if any of my colleagues happen to be here. But in their defense, most people aren't working right now because we just came out of what I lovingly refer to as the marble hellhole for 3.5 months. So a lot of my colleagues are taking some much deserved rest.
I do understand that. And I want to say thank you to you for being here. And I think it's also a huge problem that we don't have representation from that side so they can hear everything. Malika has been quite vocal, and I appreciate that. So I think that's part of the problem. Thank you for being here.
All right, thank you. I still don't see any other members with their hands raised. We'll go and take then Lakeisha.
Sorry, I didn't mean to put my hand up.
Oh, okay, no worries. Okay, any other just general questions about session? And thank you, Rep Davis, again for being here. Appreciate it.
I was going to second that, Blake. Thank you, Lauren, Rep Davis, for being on today, shortly after Sine Die, and fielding the question.
Yep.
Enriches the conversation tremendously, so thank you.
Okay, if there's no other questions, the next thing on the agenda is another public comment session here for 10 minutes. So members of the public, if you would like to make any comments, feel free to raise your hand and we'll get to you. All right, Sharissa.
Yeah, thanks. I haven't introduced myself. I'm Sharissa Fatinos. I work at the Healthcare Authority, and I see the comments by Tim and Malika, and they're exactly right. Harm reduction has the best evidence for support. I'm a family doctor, an addiction medicine doctor, and I think you can kind of get a sense of when you're going into an audience, depending on the setting and the venue, sort of how you're going to be better heard. I think because I'm a primary care doc, I view harm reduction very broadly. In my mind, I consider it treatment. And the reason I consider it treatment is because as a family doctor, there are very, very few things I cure or fix. The only thing I can fix that day is when a little kid has their elbow pulled out of the socket, and I can, by magic, and the parents love you and the kid smiles, I can put that elbow back in place. And I can do that in that visit. Everything else is a matter of listening, sitting with that person, giving them medication to reduce their risk of a long-term consequence. And if they are or aren't ready for something, I can say, okay, well, I'm here when you're here. So I think that this idea that I think I don't know the answer. I don't know how to get people to hear. I share Rep Davis's thoughts, Malika's comments, extraordinarily well said earlier, Malika, about everything. And I don't know how to get people to hear that in the age of fentanyl, unless and until we do something different, the only measurable difference we'll see is that more people die. And that's not necessary. It doesn't have to be that way. And in the process of that, they'll be more traumatized and more pain will be inflicted. So I have gone to talking about harm reduction in certain conversations as treatment, because it is what most of medicine does, and most health and helping professions. We sit with people, we let them be who they are, and we give them space, voice, and a sense of worth. That's as much treatment as anything I can do with a prescription pad. So I just wanted to share those thoughts that I know harm reduction is a button for people, and it is an important piece of our conversation for helping to support the health of people who choose to use drugs, and it is their choice and they can do that. But we all, well, myself, I choose plenty of things that are unhealthy for me, like not exercising every day, and I make that choice willfully. So I just think maybe part of this is really stop talking about in buzzwords and just say, I don't know, but thank you for letting me share those thoughts.
Thank you, Dr. Tinos. Deontay. Deontay, can you hear us? Maybe on mute.
So,
Hello, we can hear you now.
Cal Washington, or vocal one. So asked me what would I like to speak on, and I'd like to say thank you once again. This is the first time I've ever felt I could speak on something and actually be heard, and that maybe a difference would be made. And so I'd like to see that information about stuff like this be more accessible to other people like me who can give an honest opinion and probably help out with whatever. Also, just just more issues with like, there's a lot of unfairness that goes on that people like me can't speak on. I mean, we could speak on them, but no one will take us serious. And with a platform like this, again, I am so grateful for this. I feel like we can bring a lot of that darkness to light, and it'll work out better for both sides of the community. Because I mean, even as a user myself, I don't like what I see when I go around downtown. And it never used to be like that. And it's like no one has anywhere else to go that are homeless. Like we can't go home and be discreet. And you can't go anywhere else and be discreet because they kick you out as soon as you. But I mean, it's just at least people care enough to try to do something about it in all areas. So thank you guys. And that's all I had.
Yeah, thank you for your comments. Appreciate that. Thank you for speaking up. Okay. Any other comments from the public? I'm gonna go last call here. Any other comments from the public? Okay, Elizabeth.
Hello, hi, I'm Beth Barrera. I work for a managed care organization, but also just speaking as a public member. I too lost my nephew last year to fentanyl poisoning. And unfortunately, learning about the circumstances of his death, he had had an overdose 6 months prior and was seen in the emergency room, admitted to a hospital, and discharged with antibiotics. So very shocking to go through the files with my sister and sit there and say, God, they didn't even offer him naloxone. She didn't know anything about it. This was coming to me, and I'm also a physician and addiction medicine specialist. So just shocking, and to go into that space with activism. So I sit in these meetings and I listen, and I'm happy to help in any way. I really appreciate everybody's input, and the representatives, our state partners, the managed care. I mean, we are all working together to save lives and treat addiction. Just like Dr. Ficino said, it's our responsibility as healthcare providers to provide treatment without stigma and shame, and just be there for others, to hear your stories and to provide support. But thank you so much.
Thank you, Beth. Sorry for your loss. Okay, any other comments? Okay. Okay, and of course, a bunch of valuable comments in the chat here. I appreciate those as well. Michelle, do you want to cover what's on the next agenda for next month?
Yeah, so first of all, I want to make an announcement that we are going to be establishing an in-person option for future meetings beginning in June. So that applies to committee members. We won't have a space big enough for any potential, public, anyone from the public joining as well, but the virtual option will remain intact, both for committee members and for anyone else from the public that wants to join. But just so everyone knows, there will be an in-person option available at HCA. So I will be sharing, exactly where those rooms are for anyone who is able to join us in person. And let's see. So next meeting, unless we notify you otherwise, we will be having the public safety discussion in June, and I'll be sending an email to follow up with the with contacts to invite to that meeting as soon as possible, and the framework that we'll be using. And that is the majority of what the meeting will be spent doing. I think someone's not muted, right? Is that okay? So the June meeting will be dedicated primarily to the public safety discussion, or community safety, as we may end up rewording it. If it's ready, there may be also a draft of the annual report available as well. So I'll keep you posted about that. But that's it for the next agenda. So I will leave it there. And
Michelle.
are there any, oh, sorry, go ahead.
Yes, hi, Michelle. I wanted to know, do you have any information on the Say It Loud conference next month? Can we get some information on that? I know the HCA sponsors the Say It Loud conference. So can we get some, I think that it'd be great to possibly even get some more information about that for the next, if we could possibly put that on the agenda. I know public comment's done, but I would love for that, for us to get more access to celebrate and uplift our community members that are working in this in every area of health, especially for our LGBTQIA community members. So possibly we could be able to add that to our next agenda to get some more information on that.
So we have a thank you, Lauren, for putting that information in there. In the chat. Kira, did you have comment?
Yeah, so regarding the conference, I think, yeah, Lauren, May 22nd, it's going to be at Spokane at the Davenport Grand. We're still finalizing the program. There's a draft agenda as of to when breakout sessions and larger sessions will be on the Say It Out Loud page, which I put the link in here for you. We do hope to have the program ready to go within the next week, but I can't guarantee that. If you do have any specific questions, I'll put my email address in the chat, and I'll find out why the link isn't working. Maybe it's org. I'll have to double check it. But I'll put my email. Thanks, Scott. If you do have any specific questions, I am one of the planning committee leads. So if you have specific questions, please feel free to reach out.
Thank you, Kira. Appreciate that. Deontay, did you have anything else? Or we kick it back to Michelle?
Oh, absolutely not. Sorry.
Oh, no worries. No worries. All right, Michelle.
All right. Well, yeah, I think that's it, unless there's any closing comments before we all log off.
Yeah, Michelle, just in the meeting.
Oh, we lost your audio there, Michael.
Michelle, can you hear me?
Yes. Okay, it's back. Yeah.
Okay. What for facilitating and for planning the meeting. Thank you, everybody, for all the engagement. That was really media discussion. For those of you that have lost loved ones or have been impacted by these issues, thank you for your bravery and willingness to share and offering up suggestions and ideas. We will most certainly be planning for June, not only in person, but also this conversation around public safety, or community safety. Have a little grace with us, if you will. We'll give it our best to make sure we get all of those voices not only engaged, but have enough time to discern what they have to say. This does not have to be one and done. We'll give it our best in June. If we find like more conversations needed, we could certainly schedule more time after that. But thank you all, and happy May Day, and appreciate everybody being on here. So have a great rest of your week. Thank you.
Thanks, everybody. Have a great day.
And Michelle, we had Sarah can we hear more about HCA Friends for Life Youth Fentanyl OD awareness campaign in the next meeting, or just a note there? So.
Oh, thank you, Sarah. Yes. Yep, I'm happy to send some more information or get that on the agenda.
Thank you.
Thank you.
Mm-hmm.
See you in June.
Thanks, Michelle. Good job.